Assalamu alaikum. Which tonsillectomy technique? Are there better ways of doing tonsillectomy? Are some techniques better than others? And if so, how can you judge? Where is the evidence? And if there is, which tonsillectomy technique is the best? To answer these questions, this lecture will be based on data collected and analyzed from the National Prospective Tonsillectomy Audit from England and Northern Ireland, and the reports from the National Institute of Clinical Excellence in 2005 and in July 2006 and December 2006, and a review from the Cochrane at 2017, and 69 randomized controlled trials and few retrospective studies. We'll be looking for the primary outcomes to judge which tonsillectomy technique is better, including things like validated pain scores at postoperative day 1, 3, and 7, and beyond for up to 2 weeks, intraoperative blood loss, primary postoperative bleeding within the first 24 hours after surgery, and secondary postoperative bleeding after the first 24 hours, and some secondary outcomes as well in some reports, including time until normal diet was resumed and time until resumption for normal activity, and the duration of the surgery and any adverse effects, including blood transfusion and the need to return back to theater. Start this comparative study with the rate for primary hemorrhage between diathermy, coblation, or cold steel based on data from the National Prospective Tonsillectomy Audit, including more than 33,000 patients, which showed that the lowest rate for primary hemorrhage was for cold steel dissection with bipolar diathermy hemostasis. This amounted to 3 in every 1,000 cases. Similarly, bipolar diathermy dissection and using bipolar for also hemostasis, it also resulted in 3 cases in 1,000 cases of tonsillectomy or primary hemorrhage. And the last was the monopolar diathermy dissection and hemostasis with 9 cases over 1,000 tonsillectomies, and coblation with 11 cases in 1,000 tonsillectomies. The outcome was a secondary hemorrhage after 24 hours requiring returning back to theater. Again, the best rates were for cold steel dissection with ligature hemostasis, which has the lowest rate, 2 cases in every 1,000 tonsillectomies, followed by cold steel dissection with diathermy hemostasis, either by monopolar diathermy, and 3 cases of secondary hemorrhage, or bipolar diathermy in 4 cases in every 1,000 tonsillectomies. Coblation was higher, 7 cases returning to theater from every 1,000 tonsillectomies for secondary bleed, and diathermy dissection, whether the hemostasis was done with monopolar diathermy at 7 cases in every 1,000 or with bipolar diathermy at 8 cases in every 1,000 tonsillectomies. The report from the NICE 2005 data was very similar, showing that the lowest rate was associated with cold steel dissection with ligature hemostasis for all cases of secondary hemorrhage, including those who went to theater and those who did not, followed by cold steel dissection with diathermy hemostasis, whether monopolar or bipolar, and the highest rates were for coblation and diathermy dissection and hemostasis. These were the highest cases for secondary hemorrhage, all cases. When the outcome was the mean operating time from 18 different studies, the shortest operating time was for diathermy with a mean time of 16.6 minutes, followed by cold steel with ligatures and or diathermy hemostasis with 18 minutes 0.2, and the longest time taken was for coblation with a mean time of 24.5 minutes. And the outcome is time taken to return to a normal diet, we had two sets of comparisons, the first between diathermy versus cold steel, and the second was diathermy versus coblation. In the first set of data from 4 studies, 3 of these 4 studies showed that cold steel was better, and the time taken to return to normal diet ranged between 5 and 9 days, compared with 7 to 11 days for diathermy. Only one study of the 4 favored diathermy. And the second set of comparison between diathermy and coblation, one study favored diathermy and the other favored coblation, so it was not very conclusive. Now to tonsillectomy using ultrasonic scalpel. The use of ultrasonic energy to simultaneously dissect through the tissues and seal or coagulate blood vessels is used here via a disposable blade which vibrates at ultrasonic frequency, and this causes the tissue cutting and also seals the open up blood vessels by coagulation. And the temperature generated by the vibration is about 55 and should be less than 100, so it should be cooler than the use of conventional diathermy. The use of the ultrasonic scalpel for tonsillectomy may result in higher rates of secondary hemorrhage than the other techniques. Going into results for the ultrasonic scalpel, the outcome here is primary hemorrhage, and there are 2 retrospective studies on this when the outcome is primary hemorrhage. The first retrospective review of 316 patients, and this showed that the ultrasonic scalpel group had a 1% primary hemorrhage, followed by the diathermy group at 3% and the cold steel dissection group at 3% again. In the other study, again retrospective, for 407 patients, the primary hemorrhage rates were again 1% for the ultrasonic scalpel, 2% for dissection with bipolar diathermy, and 7% for dissection with monopolar diathermy. So there is some evidence here from retrospective studies that the ultrasonic scalpel can produce less primary hemorrhage compared to other techniques. But if the outcome is secondary hemorrhage rate between ultrasonic scalpel and other techniques, then the ultrasonic scalpel produces more secondary hemorrhage than the others. The evidence came from 3 randomized controlled trials. The largest included 120 patients, and this showed that the rate for the ultrasonic scalpel was 8% secondary hemorrhage compared with 5% only for the diathermy group. In a smaller randomized controlled trial of 21 patients only, one side of the tonsillectomy was done by the ultrasonic and the other was done by diathermy, and this showed a bleeding on each and 2 patients, one from each side, so it wasn't favoring any technique over the other. But the other randomized controlled trial of 28 patients showed that the ultrasonic scalpel, again this last randomized controlled trial, was within patients, one side was ultrasonic and the other was the cold steel, and this showed 11% secondary hemorrhage, all coming from the side of the ultrasonic and 0 secondary hemorrhage for the cold steel side. This comparison between the ultrasonic scalpel, cold steel, and diathermy with the outcome of pain in the first 7 days and pain after 2 weeks, including 6 studies, 4 of them for the pain in the first week, and that showed that the pain scores for the 3 techniques, the ultrasonic and the cold steel and the diathermy, was more or less similar in the first week. The other 2 studies, randomized controlled trials, one with 32 patients, and this was monitoring pain after 2 weeks or more, and this showed that the site of the tonsillectomy that had the ultrasonic scalpel was significantly a greater pain than the other side, which was done by blunt dissection. This randomized controlled trial was in favor of the other techniques, the blunt dissection, compared with the ultrasonic scalpel. Another randomized controlled trial with the same idea for pain after 2 weeks, this time including 120 patients. Only 3 patients had pain in day 14 or more, and all the 3 were from the diathermy group. The outcome here is time taken to return to normal diet after ultrasonic or diathermy or cold steel, and 4 studies looked into this and generally found that the ultrasonic scalpel patients returned to normal diet either in a similar time or earlier than the other 2 techniques. And the largest of the 4 trials, 172 patients, showed that these patients returned to normal diet, the patients who had ultrasonic scalpel, earlier than the other 2 techniques. In day 1, 44% of the ultrasonic scalpels returned to normal diet, compared to just 23 with the other techniques, diathermy or cold steel dissection. And in day 3, almost 3/4 of the ultrasonic group returned to normal diet, compared to less than half of the other 2 groups. And to sum up the results of the ultrasonic scalpel in tonsillectomy, the data showed that the rate of primary hemorrhage with the ultrasonic scalpel was lower, and that compared to cold steel or to diathermy, but the secondary hemorrhage rate was higher. Between 8 and 11% of the ultrasonic group had secondary hemorrhage. The pain scores up to the first 7 days were similar between the 3 techniques, but pain at 2 weeks was significantly higher in the ultrasonic group. The ultrasonic group patients returned to normal diet either in a similar time or earlier compared to the other 2 techniques. We now move to tonsillectomy using lasers. A laser is used to dissect the tissues and also to coagulate the blood vessels, and this can involve in tonsillectomy one of 3 things: mostly resecting the whole tonsil within its capsule. This is complete tonsillectomy, laser tonsillectomy, or reducing the size of the tonsil by just removing part of it, leaving the capsule and the other part of the tonsil intact. This is laser-assisted tonsil reduction, tonsillotomy, or vaporizing the tonsil tissue. The use of the laser for tonsillectomy may result in higher rates of hemorrhage compared to other tonsillectomy techniques. When the primary outcome is intraoperative blood loss, the laser has a better result. The intraoperative blood loss with laser is less compared with cold steel dissection. But if the primary outcome is primary hemorrhage within 24 hours after the surgery, a randomized controlled trial showed that 11% of the patients had a primary hemorrhage following laser tonsillectomy, compared to just 6% who had cold steel dissection. And the same pattern is seen with secondary hemorrhage when laser is compared to other techniques. In a randomized controlled trial of 38 patients, one side was done with a laser and the other with cold steel. 6 patients had delayed bleeding after 24 hours, all from the laser side. 2 of them required readmission to theater. There was no incidence of secondary hemorrhage on the cold steel dissection side. In another trial, the highest rate of secondary hemorrhage in a case series report was from the laser group, with 19% of patients with laser had delayed bleeding, and 1 patient out of the 54 patients in this case series had also suffered from a laser burn to his tongue. These results of the secondary hemorrhage is consistent with the data from the National Prospective Tonsillectomy Audit in England and Northern Ireland, which also found that the lowest rate of secondary hemorrhage were associated with the cold steel dissection with suture hemostasis. there is a slight increase in the risk of post-operative hemorrhage with laser tonsillectomy compared with cold steel, either primary or secondary delayed after 24 hours. There is also the known risk of laser injury to the patient's face or heat damage to the tongue or other parts of the pharynx. The outcome of the comparison between laser tonsillectomy and other techniques is post-operative pain. 5 studies looked into this, and 4 of these 5 studies showed that initially in the first 24 hours, the patients who had the laser tonsillectomy or the site of the tonsil dissection done by laser had less pain compared to the other techniques. This is in the first 24 hours. However, at subsequent assessments in day 3, 7, and up to day 14, the site who had the laser or the patients who had the laser tonsillectomy had higher pain scores until at least 2 weeks after surgery. And the outcome for the comparison was wound healing, comparing laser with other techniques. 3 studies looked into this, and all the 3 studies reported that the wound healing was slower after laser tonsillectomy compared with cold steel dissection. To sum up the data on tonsillectomy using lasers, it showed that intraoperative blood loss with laser is less. The primary hemorrhage was higher at 11%, and secondary hemorrhage was also higher, up to 19% of the patients with the laser tonsillectomy. Wound healing was slower, and post-operative pain, although less in the first 24 hours, was greater after this, up to 2 weeks. We now move to the use of coblation in tonsillectomy. Coblation, which has been called cold ablation or high-frequency electrosurgery or radiofrequency ablation. The technique involved passing radiofrequency energy in a conductive medium such as a solution of sodium chloride, isotonic sodium chloride, for example. This results in a charge-carrying ions, and ionized ions that break organic molecular bonds at a much lower temperature than other forms of electrosurgery, the low temperature between 40 degrees and 70 degrees centigrade. And this, to do this, you use a coblation wand, which is basically a bipolar probe used for the dissection and also for coagulating the blood vessels. Data on coblation tonsillectomy came from the Cochrane review in 2017, which analyzed 29 different studies, 7 of them including only adult patients and 16 only children, and 6 including both children and adults. And in 16 of these studies, there were adequate randomization techniques to compare results from the coblation to other tonsillectomy techniques. And the comparative studies showed when the primary outcome was either primary or secondary bleeding between coblation and other techniques, that the risk of the primary bleeding within 24 hours was similar to other tonsillectomy techniques. The risk ratio is almost 1. If the outcome is the secondary bleeding, then the risk ratio is higher at 1.36. This is more than a third compared to other techniques. It translates to about 5% secondary hemorrhage in the coblation group versus a 3.6% secondary hemorrhage in the control groups, the other tonsillectomy techniques. This is the meta-analysis chart for the secondary bleeding, which showed that coblation group patients had significantly more secondary hemorrhage compared to the controls, the other tonsillectomy techniques. The basis for the comparison is post-operative pain. Patient in the coblation group at day 1 had less pain compared to the other tonsillectomy techniques. And this continued until day 3 as well, although with a narrower margin. But at day 7, there was little or no difference between the different tonsillectomy groups if pain is the outcome. So although the results suggest that pain may be slightly less in the coblation group between days 1 and 3, the clinical significance is not very clear. Are the meta-analysis results for pain at day 1 and day 3, and both showed that patients who had the coblation tonsillectomy have less pain compared to other tonsillectomy techniques. And finally, to sum up the results for the coblation tonsillectomy, the data supports that coblation technique may cause less pain on post-operative day number 1, although the difference between the coblation and the other techniques is small and may be clinically insignificant. And this continues at day 3, although the difference decreases further. But at day 7, they have similar rates of similar scores for pain. They have similar rates, the coblation and the other techniques, of primary bleeding, but an increased risk of secondary bleeding in the coblation group. For every 1,000 patients of tonsillectomies done with the coblation, you would expect 50 secondary hemorrhages, and compared to if 1,000 tonsillectomies were done with the other techniques like cold steel or diathermy, you would only get 36 secondary hemorrhage. The evidence supporting these findings is not very powerful. It's either low or very low because there is high degree of uncertainty about the results. This, we come to the end of this lecture on which tonsillectomy technique. السلام عليكم.